Okay, and Jess, do you think are we good to go, or do you want to give it a couple minutes?
Yeah, let's get started. I know that it's a tight hour, so let's go ahead and get started if you're all ready.
That sounds good. Well, hello, everybody. Welcome to this morning's webinar. Really glad that you're all here with us today. I'm Alex Hulst. I'm based out of Grand Junction, Colorado, which is closer to Utah than Denver, if you're familiar with the state. So I'm from a company called Rocky Mountain Health Plans, and I'm here joined by my co-presenter, Jennifer Tracy, today. And we're talking about creative funding strategies for family-based models of care. And we're going to bring together different payer perspectives and provider perspectives that we've gathered just over the years with our work. So we thought we'd tell you just a little bit about ourselves. So I'm Alex. I work for Rocky Mountain Health Plans. And so that is a health insurance company that has most of our largest chunk of business comes from Medicaid in Western Colorado. So most of the clinics that I work to support are in rural or frontier areas. I've worked for Rocky for about 7 years now. My background is as a couples and family therapist. So I'm a medical family therapist and really love getting to do clinical work. And I was thinking about, why Jennifer and I spent some time kind of over the summer as we were planning this, of thinking of, what is it that personally for us makes working with families so important? And so I was thinking just about, how I decided, first I decided I wanted to do couples and family therapy. And then, when I was in the middle of my training program, my grandfather had a stroke. And it really kind of sped up some of his dementia symptoms. And, several years later, that ended up creating just a lot of changes and challenges within our family. But the thing that really inspired me to go into medical family therapy was seeing how it wasn't only bad things. Even though there was a lot of really hard things that happened with that stroke, I saw the way that my family, which is typically very dramatic and has a lot of challenges with it, that people really came together and found a way to be more kind of kind, more understanding, better, more intentional with communicating. And it really opened up some positive things with my grandpa's personality, which were kind of surprising. He'd always been this very engineer type who never talked and gave me math problems for Christmas. True story. But he all of a sudden became a lot more warm and shared a lot more stories. And so I thought, if that's what I can do as a family therapist, is helping families make sense of these really difficult challenges with health things and look at it of both the hard things and also hold on to the good things that come from it. That's what I want to be able to do. And so that's how I ended up coming into medical family therapy. And then when I had the opportunity to work for Rocky as an insurance company, I never would have guessed as a therapist that I would work for a health insurance company. It just wasn't on my radar at all. But I thought that what I can do is bring together this kind of operational mindset that I have and trying to help clinics do coaching to help them support integrated care. And as a family therapist, that's a place that I can really advocate for moving beyond just patient-centered models of care to looking to be into the broader system and support families. And that's a voice that maybe isn't already present. And so that's part of the reason I'm really excited to be here with you guys today, just sharing a little bit about what I've learned over the years and how I try to think in my own clinical practice and then with other clinics that I offer coaching and consulting with, of how do we help support family models of care. Jennifer, you want to tell us a little bit about yourself?
Yes, good morning, everyone. My name is Jennifer Tracy. I'm the Senior Director of Growth and Sustainability for the HealthySteps National Office at 0 to 3. And I spent my last 20 plus years in some shape or form working with state Medicaid agencies and Medicaid health plans to improve the way care is delivered to Medicaid and CHIP beneficiaries. And before I came to 0 to 3 in 2015, I worked at the Lewin Group in the States and Payers practice and at United Healthcare. So share some of Alex's payer experience. And at United, I worked in the community and state line of business as the Medicare, Medicaid Federal Policy Director. I'll share more about HealthySteps in just a few minutes, but my current role at the national office is really to lead our work in identifying sustainable public funding sources for our HealthySteps sites across the country. So we do a lot of work with state Medicaid agencies, Medicaid health plans, other state agencies, health systems, and now recently the federal government to try and unlock new funding pathways to support preventive Dyadic services and supports for young children and their families. The HealthySteps model is one of several programs at 0 to 3. 0 to 3 also has infant toddler court program, in our 0 to 3 Policy Center. And for those of you who aren't familiar with 0 to 3, it was founded in 1977, and our organization's mission is to ensure that all babies and toddlers have a strong start in life, while recognizing that too many families face social and economic challenges, especially these days, which can place young children at heightened risk for negative life outcomes and lifelong gaps in achievement. And similar to Alex, I have a story about my passion for family-based care, and it really comes from one of my own experiences with severe postpartum depression with my first child. I was never ever screened for maternal depression. So it's a while back, but I was lucky enough to have commercial insurance, longstanding provider relationships, and resources to navigate our health system. But even with all that, no one was asking me how I was doing. And again, never was screened formally. Knowing what I know now about the first 3 years of life of a child, and the importance of those early years, I'm really shocked that no one saw how much I was struggling for the first 6 months after my child was born. And HealthySteps is definitely a model that would have made a huge difference in my life and my son's life. And so now my job is really dedicated to making sure that new parents and caregivers have the tools that they need to be as successful as possible in supporting their child's needs. And alongside that, encouraging payers to reimburse for preventive dyadic services that we know are critical for families to support that early childhood period.
Thanks, Jennifer. Okay, let's go ahead and get started with what we're talking about today. So we just wanted to share we don't have any financial disclosures to share. We do want to hear a little bit about some thoughts that you guys have. So obviously it's more interesting for us to have a little bit of interaction. It'd be better if we were all able to be together. But Jennifer and I wanted to use Menti today because we wanted to create a couple word clouds. So if you guys don't mind playing along with us, there's a couple different ways you can do this. You can either, if you're on your computer, you can like pull up your phone and your internet browser and go to Menti, MENTI.com, and you'll enter the code that's at the top of the screen. It's 1485 and then a space and then 1037. Or if you're on your computer, you could also like pull up a new internet tab and go over to that website. So there's 2 questions we're going to ask you to play along with us today. I'm going to switch to a different screen here. And these are the 2 questions we're asking. So the first one, and these are just a couple words that you're going to enter in, of what do you think are the core elements of family-based care? So I'm going to give you some time to just enter in a couple words, and hopefully we'll start seeing some things pop up on our screen here. And if anybody runs into trouble, let me know. Oh, good. I see words popping up. That means things are working. Yeah, these are great words coming through. So some of the big ones that are coming up, if they're bigger, that means more people are probably saying something along those lines. I see collaboration popping up several times, that it's family-centered, that it's all about relationships, having some cultural responsive elements, being systemic, having continuity, attending to caregivers, all these things that are probably, for those of us who are on the call today, it's probably that, being family-based and family-centered comes very naturally to you. It's part of a value that you hold. And so it's cool to see all these words kind of popping up and thinking about, that this is part of offering whole person care, that it's not just based on an individual person, but it's centering all those relationships and the collaboration and the different interactions that all of those different people have in patients' lives. So, okay, the second question, and I think it should prompt you to go to that second question is, let me go back here. So this one is, what's the value of family-based care? So when you think, if you were to try to describe to either a fellow provider or maybe a payer or some other sort of a stakeholder, what are some of your big words that come to mind that show the value of family-based care? These are great. So yeah, we know that the value is that family-based care is comprehensive. It has an impact on more than just an individual person. It impacts the entire family. It creates that second order change, not just first order change. So hoping to be more lasting and having, being able to do more preventive work, which is huge. And we know, I think so much of that prevention piece is really essential, especially as our health system is trying to improve health outcomes over time and to be able to manage costs that are very high and rising, that I think we do really have to think in that prevention space. So I love seeing prevention in particular come up on that, because it's efficient and it actually, impacts more than just one person and creates more of those lasting changes. So thank you guys. All right, we'll give you a break. I'm going to go back to our slides here. So we talked about some of the things that we saw from audience participation. I'm going to go ahead and talk. So I'll talk first. Oops, I went all the way back to the beginning. So I'm going to share a little bit about what I do at Rocky Mountain Health Plans and some ways that our particular payer system, that we could look through that lens of how we can support families in care. And then Jennifer's going to talk about some of the work that she does with 0 to 3 as well. So some of you, if you're from Colorado, you might be familiar with Rocky Mountain Health Plans, but if not, just a little bit, this map is busy, but I just wanted to give you an idea of the geographic space that we're in. So I mentioned that I'm in Western Colorado, which is this red part of the map towards the western side of the state. And so the way that Colorado breaks up Medicaid management is that there's what's called regional accountable entities, or these regions that you see on the bottom. Rocky is region 1, which means that we are responsible for overseeing Medicaid in all of those different counties. And so Mesa County is over here where I'm at in Grand Junction. The rest of these are pretty rural or more remote, some ski resort areas, since we're in Colorado. So we have over 250,000 enrollees in our health plan in different groups with Medicare Advantage, with Medicaid, with some dual special needs plans, and some individual exchange plans as well. And so we have over 21,000 providers and facilities across our state. So we have a pretty broad network and a pretty large amount of geographic area to cover. So just in terms of our mission and thinking about, who Rocky is thinking that we have always really tried to take the initiative and putting our members first, and improving the health of our communities, not just those that are part of our members. And so we try to offer innovative health plans where we're really changing things up, trying to look at what do members need to be successful, to be healthy, to be well, and recently taking a lot of interest in social determinants of health and working on projects like housing and food insecurity that we know are related to health, but aren't necessarily just medically oriented. So we really try to put people above profits. So we are recently part of the United Healthcare system about 5 years ago, and so we're integrated within them as well. But we have that basis of being local, being regional, being initially created in the 70s by a group of physicians who wanted to create a health plan that worked better for patients and providers in the network. And so, even though a lot's changed since the 70s, that still is very much ingrained in us. And I shared this, not just to talk about Rocky's values, but I think it's important for those of you who are listening and thinking about wanting to get to know your payers better. It's worth looking at their mission and their vision statement and what are their values that they say that they hold. Because if those are the things that they say on their website or in marketing materials they send out to you, when you're looking to approach your payers, those are good talking points to look at to hold them accountable to those things as you're proposing projects or you're looking for ways that you can integrate more family-oriented work, of if anywhere that you can align some of that language of the clinical interventions and the things that you want to try to get funding for. If you can align that with part of their mission statement or their values, you'll have a greater chance of success. So we all know that for most payers, paying for family-oriented care is not really a strong point, which is probably why many of you are on the call today and kind of interested in learning more about this. And so I would say, across the board from what I've seen in the payer landscape, most are still really focused on patient-centered care. And they take a lot of pride in that, of not being physician-centered or not being health plan-centered, but they want to be patient-centered and whole person care-oriented. And they're often looking for ways to be innovative and get ahead of the curve, both in improving health outcomes and patient satisfaction and controlling costs. And so I thought of how we can kind of think through some of these things that, Rocky as a payer does to support family-oriented care. There's things that you can look at that are obvious, like paying for a family therapy code, that's relatively straightforward. It's something that's included in contracts with our clinicians, but we have to look outside the box because that's not enough. And we want to try, if we're really being integrated and pursuing that whole person care, we have to kind of think through some creative lenses. And so over the last couple of years, I set a goal with, we set goals each year as just employees with our managers. And so one of my goals for the last several years has been looking for ways to strategically align family-oriented care within key parts of our business. And so that's what kind of helped me be able to put together some thoughts here and hopefully give you guys a little bit of inspiration of some things that you could pursue with some of the payers in your groups as well. So like I mentioned, of course, we want to look at the fee-for-service reimbursements for things like family therapy, psychotherapy codes. We don't want to leave money on the table that's available. So when you're working with a patient and you feel like it's appropriate to include their family in that care, of course, we want to bill for those codes. And so, if that's included in your contract already, great. If it's not, that's a good chance to advocate and maybe share with your payers of if that code is not included in that contract already, what's the benefit of including that and seeing if you can get a revision to that contract. But the other thing that we have to think about is even if family isn't in the title of whatever the funding stream is, that doesn't mean that we can't apply family-oriented work to those types of efforts. And so as a family clinician, I try to think through a family lens, even if I don't see family explicitly represented. So when I look at Rocky and some of the things that we do, these were some of the things that came to mind for me. So we have, we do some fee-for-service payment models, but we're shifting a lot of our payment contracts to alternative payment models and different value-based contracting strategies. And so there's a lot in there, but one example that I wanted to talk about was our community integration agreements, or CIAs, which sounds very more interesting than it is. Sounds very spy-like. But our CIAs are essentially things that they're a group of payments, or it's a group of funds that we set aside for high-performing provider groups. So we have a tiering strategy where we assess all of our different providers and clinics in our network, and those that are performing at the highest level are eligible for a community integration agreement. And so essentially, that's a contract to be able to share a lump sum with that practice to be able to support integrated behavioral health or translator services or care coordination, different things that the practice has identified that they have a gap in being able to meet through the fee-for-service reimbursements. And they would like additional funds to be able to support their integrated behavioral health is mostly what they're about. And so when I thought about, these CIAs, there's some that have really focused specifically. That's a great opportunity to look at family-based care. And so some of our examples that I thought of were one of our pediatric clinics has specifically set a goal of doing ACEs screening, or adverse childhood experiences screening, with parents in their practice to try to understand parents' experiences of childhood trauma and how that impacts their parenting. And so some of their CIA funds are designed to get their behavioral health provider training in ACEs to be able to offset some cost of being able to do some of those interventions, even if they're not billable, because they're shorter periods of time or whatnot. And then we have another clinic that is starting a new program where they are embedding a family therapist within the hospital system, because that's not something that's typically been billed for in the past. And so they're focusing on a small group of patients who have high utilization in the emergency department and high hospital readmissions. And they're using that family therapist to meet with the patient during their inpatient hospital stay, to work with their families and their support systems in the home, and to be able to do outpatient behavioral health work. So those are some of the things that I thought about that, it's not explicitly written that family work is in these CIAs, but these are things that clinics who are passionate about family-oriented work have advocated to use those funds through a family-oriented lens. The other thing that I thought of, we've worked in the past with community health workers. I mentioned that we're doing some social determinants of health work. And so some of you might be familiar with the Accountable Health Communities Model, or AHCM program. It's a federally funded program. And so thinking about, that if if people have, if patients are struggling with food insecurity, housing, or transportation, it's often not just impacting a single person within that family, but it's impacting the entire family. And thinking about our care management department, we have care coordinators who are embedded that do different types of assessments and connect our members to different resources. And so I had asked them, how do you do family-oriented work? And so they mentioned that they often try to include family members in meetings, particularly when a patient, needs extra support or maybe has a harder time tracking medical information and making decisions. So they try to be intentional about inviting a family member or a support member to join a meeting. And they try, to even themselves join medical visits to help advocate for patients if they feel like they don't have somebody in their life who could help them make sense of that information or be a support to them, that our care coordinators are happy to join their medical appointments too. So I work within the clinical quality improvement department, and I had mentioned that, I had set a goal of trying to do more family-oriented work to align with our business goals. Because one of the things in talking with my manager was thinking about, we are all, and probably every single one of you can relate to this, that we're all spread thin. We have lots of different goals, lots of different projects we're working on. And so what we didn't want to do was to create something brand new that was like a new family-oriented care sort of work that we're asking providers to work with us on and tracking specific data on, because we felt like that just wouldn't have a lot of uptake, especially during COVID. Resources are pretty thin. And so instead, what we tried to do was look at what are we currently doing and how do we embed a family-oriented care lens within that. And so some examples of that. So a lot of the things that my department does is different types of trainings and webinars for providers. And so we looked at how can we embed some family-oriented care pieces of that. And so we have done some different topics about like supporting family caregivers. We've done some basic skills of working with families in medical appointments. We did a session on reducing avoidable emergency department visits in the pediatric population. And I was the presenter for that and specifically tried to look at it from a systemic lens, because much of the emergency departments, utilization things that we see in the literature and different trainings that I've gone to are very individually patient focused. But especially with peds, we know that it's not just the 6-year-old who's deciding to go to the emergency department, it's their family or whoever's the caregiver at that moment. And so we need to talk about, parental anxiety, or helping how parents make decision making, how, clinics can reassure parents or help them navigate the process of deciding whether to call their primary care provider or go to the emergency department first. And so trying to embed some of those things that are naturally high priority at the health plan because they're associated with high cost and poor health outcomes, and looking at it through a family-centered systemic lens. Another example was our diabetes gaps in care project. So this was a pilot we did over the last year with just a handful of practices to try to help identify some discrepancies where patients either didn't get an A1C test over the last year, or they had an A1C test, but it was high, and showing that their diabetes is not being very well controlled. And so I had advocated to specifically include a module on that of if there's patients who have had a history of having a really hard time of managing their diabetes, maybe we need to think about it through more than just an individual lens, but we need to think about it through a family lens of, can we understand their health beliefs? Can we understand some cultural factors that are impacting their diabetes management? Can we invite them, patients, to be intentional about having a family member join their appointment so their family member can understand what their treatment regimen is looking like and offering support at home? So these are types of things that, currently were in existence, but we didn't create something brand new, but tried to embed some family-centered care pieces in. And that's what I would encourage you to think about too, is, what's already on your payer's radar or your practice's radar, and how can you build a family lens within that instead of starting something brand new from scratch that might be really resource intensive. So it's not a surprise to probably any of you that health plans are collecting a lot of data on clinical quality measures, or CQMs. And so these are essential for things like Medicare stars ratings, for HEDIS measures, and just different contracts that health plans have with the state or other sort of entities. And so they're passed along to practices of, we ask practices to track your patients that have diabetes in control under a certain A1C, or hypertension control. There's things like depression remission scores, or how often your patients are engaging in treatment following an SUD-related emergency department visit. These are all just examples of metrics that my plan is asking providers to look at through different ways. And so again, just thinking about, none of these are explicitly family oriented. But if I'm a clinician working in a clinic who's being asked to report on these CQMs, how can I think about how can I improve that depression remission rating by offering some family-centered interventions? Like which patients would be a good candidate to be intentional about that with so that we can improve our performance on that measure and improve the quality of life for that particular patient. So I thought about this, and I kind of thought through the lens of what we did in our diabetes gaps in care project of what are some different ways that if we want to improve some of those clinical quality measures, what are different avenues that we could do that through family engagement? And I tried to keep this particularly simple, especially because the clinics that I worked with in that diabetes gaps in care project are not particularly, I would say, progressive with family-oriented care. And it was much more driven from the medical side of things as opposed to behavioral health even. But things that I had encouraged them to think about of ways to use family engagement as a lever to improve this CQM performance was really simple things like inviting family members to join appointments, supporting patients in teaching them how to ask for help from their support system, that's something that maybe we take for granted if we, value and we feel comfortable asking our families, but many of us have probably noticed we have to teach our patients how to ask for help and what they want help with. Revisiting treatment plans for high-risk patients so that they can identify, opportunities for family engagement. Even if family doesn't come to appointments, asking about, how their family perceives their diabetes or, different health behaviors or dietary changes they're trying to make. And then thinking about caregiver burden. And so, with different conditions that there may be different caregivers involved. And so figuring out what their level of burnout might be and offering support as needed. So these are things that as you're looking at those clinical quality measures and thinking, okay, how could I improve that through a family lens? These are some places you could consider starting. So if I were a clinician, thinking about, okay, I want to get started with more family-based care and using that as a way to try to improve some of these performance measures, these are some tips that I had thought of in terms of asking your office manager that you just even asking, you might know this off the top of your head, or it might not be something that you're very familiar with, but asking your office manager or your QI director, somebody in the clinic, what are the highest priority quality metrics that our clinic is tracking right now? And typically those are going to be ones where there's financial incentives on the line. And so those are really good places to start. Could be diabetes, could be hypertension, could be any number of things. And so from there, then you can think about, how can you help as a behavioral health provider or as a clinician who's really interested in engaging families more. And so helping, support patients in those behavior changes, involving their family, and being able to be part of, oftentimes clinics have like a quality improvement team. And maybe that's something that you're part of or you'd like to ask to join so that you can understand the data of where you're starting. And so as you're working intentionally to involve family members more, you can track some of those changes to figure out, are you moving in the right direction or do you need to try something a little bit different? So Jennifer and I both at the end of our sections wanted to kind of narrow it down to some of those critical success factors that we thought of. And so one being that I think you really have to educate your payers about the benefits of family-oriented care beyond patient-centered care. Don't take for granted that they know. It's not that payers don't care about families, but they're very focused on like who are their covered lives and their particular beneficiaries. But many of those things, like in that word cloud that we had about what's the value of family-based care, using those types of lenses to think through that it's cost effective, it offers prevention, that it creates this second order change that has a lasting impact. Those are things that they may not be thinking through that lens. And so those are important things for you to be able to share if you're going to propose some sort of a project that's working on, a particular metric that's part of your contract there. The other thing too is thinking about as you interact with different representatives from your health plans, looking for the champion who cares about family. And so thinking about, some of those stories that Jennifer and I shared at the beginning, those are really powerful things that help get people's ears. And so trying to understand what is it that drives people that work at the health plan and are part of those contracting pieces, and listening for ways that they might be really interested in supporting families as well. I talked about, not just sticking with fee for service, but also leveraging alternative payment models through that. And certainly if those are words that are not very familiar to you, ask your office manager, and they are very familiar with that. And they're able to help look at your particular payer mix and understanding what sort of avenues you can use. And really identifying specific patients or clinical quality measures that align with a high priority, so you get the biggest bang for your buck when you're trying to do more family-oriented work. All right, that brings me to the end of my section. And Jennifer, I'll turn it over to you.
Thanks, Alex. I wanted to provide a quick overview of HealthySteps for those of you who aren't familiar with the model, and then go into some detail around some of the exciting developments that our team at the HealthySteps National Office has been working on in California and as well as in some other states. HealthySteps, it's an evidence-based model. It's an interdisciplinary pediatric primary care program that exists wherever well child visits take place. So that can be a primary care setting, it can be a federally qualified QHC, family practice. Really, well child visits are the key to the model. And the model really promotes nurturing parenting, healthy development for babies and toddlers. So the focus is children birth through age 3 and their families. And HealthySteps specialists are an integral part of the model. And those individuals are child development specialists. They're integrated into the pediatric team, and they can provide short-term behavioral and developmental consultations. They'll provide referrals to services, and then they can provide more intensive services when needed. They also help support the practice with universal screening efforts. And I will say, HealthySteps is a universal model. It's meant for all children, but it can be a wonderful asset, particularly in areas where there have been persistent inequities for families of color or families with low incomes. Over on the next slide, HealthySteps, as I mentioned, does exist within the pediatric setting. And we know that almost all families take their babies to see a pediatric primary care provider. And we like to think of the pediatric setting as being a positively stigmatized setting, because parents trust their pediatricians. They feel good when they take their children in for their well child visits. And we also know that parents attend 12 to 13 well child visits within those first 3 years of life alone, half of those occurring within the first year of a child's life. And so it really creates a powerful environment for building trust with families and really addressing issues that are impacting not only the child, but the entire family. Over on the next slide, I just wanted to quickly highlight the 8 core components for all of our HealthySteps sites. So if you're going to deliver HealthySteps, you have to deliver all of these services. The first two core components are around screening, and those are screening for children on the child side, developmental, social, emotional, and behavioral health screening for all children birth through age 3. And we also screen for family needs, including, as I mentioned earlier in my little intro, postpartum depression, risk and protective factors, and screening for social determinants of health. Because again, we know that whatever is impacting the caregiver also directly impacts the child. We also require a HealthySteps site to offer a child development support line, which can come in a variety of forms, whatever works for the practice. It can either be phone, email, portal. It just allows families in that practice to reach that HealthySteps specialist with any developmental questions that they have. We also know that some families may require short-term support in the form of those child development and behavioral consults that I mentioned. And those would be with the HealthySteps specialist, and those could address issues such as sleep training, toilet training, and biting, things that oftentimes the pediatricians or other clinicians will bring up and may not have time to work on with families more intensively. And so these consults offer short-term support for families to address specific issues. And then once they're hopefully resolved, the family can, pull back working with a specialist. But if not, the specialist can continue to work with them on a longer-term basis and possibly provide appropriate referrals and make sure that families receive those services. Our 5th core component encompasses care coordination and systems navigation. Our specialists spend a lot of time linking families to services, making warm handoffs, and more importantly, following up to make sure that families receive services and that we know referrals stick. This includes referrals to services like early intervention, housing, food insecurity referrals. It really runs the gamut. And again, whatever is impacting that family and child, our specialists can certainly help try to address. Our specialists also support families through a host of positive parenting guidance resources, anticipatory guidance. Both are key parts of our model. Our national office, because we're affiliated with 0 to 3, provides sites with a variety of resources to help inform the discussions that specialists will have with families. And then finally, for our families that have the most intensive needs and need additional support, the HealthySteps specialist can be available to attend every single well-child visit within that first 3 years of life. And the specialist will jointly manage that visit alongside of the pediatrician or clinician. Over on the next slide, this outlines how we think about the tiers of service within the model and how the core components exist across the tiers. We know that every family has unique needs, and these tiers really help our sites think about how to meet those needs in the most efficient way and effective way possible. For child screenings for family needs, and the child development support line, those services have to be provided to all children in a practice birth to 3 and their families, and that's what we consider tier 1 along the bottom. From there, we know that screenings, clinical observations, our work with families can really help identify families that might need shorter term supports. And as we like to think about it, these are families where we're seeing the lightest of pink flags that could benefit from some additional short-term help from the specialist, maybe in 1 to 3 visits, or that might need assistance in being linked to services. And then once those needs are met, those families can bump back down to tier 1. So tier 2 is inclusive of the short-term supports in addition to all of those tier 1 services below. And finally, for those families that need additional support, those are the ones that can receive the team-based well-child visits, those first 3 years of life. That's our tier 3. And again, those families receive all of the services in tiers 1 and 2. And I'd say we typically don't see a lot of families moving out of tier 3. Most of the movement is between tiers 1 and 2. Over on the next slide, I'm not going to go into detail, but I did just want to note that HealthySteps, we went through a randomized control trial in the early 2000s. That evaluation, along with subsequent site level research, really shows that HealthySteps impacts a wide array of outcome areas that are of particular interest to payers, providers, policymakers, and of course, the families that we serve. And there's more information about all of these on our website at 0 to 3 if you have interest. Over on the next slide, the main ongoing cost of HealthySteps is the salary and benefits of the HealthySteps specialist. And our site network funds those costs in a variety of ways, including through payer reimbursement for some of those services, other public sources such as state budget, state agency funds, federal grants, and some philanthropic funding that can be really helpful in covering up some of those initial startup costs as HealthySteps specialists build their caseloads. Our national office, for our part, really advocates for a braided and diverse funding approach that really doesn't rely on one sole source of funding. And the majority of our sites do use a combination of the funding sources on this slide. And then for the rest of our discussion, I really want to focus on some new and exciting billing options for preventive family-based care services in California, and then highlight a few other things as well. There have been lots of exciting developments in California. Some of you have been following in the way that Medicaid there pays for family-based services. And our national office has been really fortunate to collaborate with some wonderful partners on the ground to help advance those pathways. It started in late 2019, feels like forever ago. Our national office co-created a Dyadic payment proposal with some of our California partners on the ground for Medicaid health plans in San Francisco County. And it was around paying for HealthySteps services that are not traditionally reimbursed for our healthcare system. So some of those tier 2, tier 3 services. And mainly those aren't currently reimbursed because they are preventative in nature. We are trying to prevent future behavioral health diagnoses in children through HealthySteps. And so the proposal to those Medicaid health plans really outlined a value proposition for HealthySteps that emphasized that the model's low cost, it's evidence-based, it has associated short-term Medicaid cost savings that are dyadic in nature, positively stigmatized, it's delivered in a universally accessed setting. It really presents an opportunity to address child development and well-being, as well as caregiver issues, speaking to the dyadic nature. And we have the ability to impact outcomes on both the child and the adult side, which obviously addresses some payer pain points and provider pain points. So out of this proposal in 2020, San Francisco Health Plan approved a first ever that we know of set of payments to University of California, San Francisco, which was one of our HealthySteps sites for preventive behavioral health well child visits. So just let that sink in for a minute, sort of a new concept that would include tier 3 HealthySteps visits. And those would be delivered by a licensed behavioral health clinician. And the visits could be in conjunction or separate from a physical health well child visit. And they allowed for a focus on both the preventive physical and behavioral health of the child and the caregiver. So really, I think from our national office's perspective, driving home the meaning of true parity. And then that breakthrough with San Francisco Health Plan really paved the way for bringing this type of county level benefit more broadly to the state of California. And in May of 2021, Governor Newsom announced the introduction of a first of its kind statewide Dyadic Medicaid benefit. So in June of last year, the governor approved $800 million for the new benefit. That will include integrated physical and behavioral health screens and services for the family that's based on HealthySteps, very similar to what we helped build at San Francisco Health Plan. And Medi-Cal is currently working to define the benefit, and the estimated timeline for rollout is January of 2023. I will share that the state's most recent public guidance on how the benefit will be implemented is that it really indicates that Medi-Cal will cover integrated physical and behavioral health screenings and services for the whole family and not just the child who is the identified patient. So getting to some of Alex's points that she made. It's a benefit that's really important for families in which the child is maybe enrolled in Medicaid, but the parent or caregiver is uninsured, and yet there's a need for dyadic treatment. And those services will be delivered during a child's visit in which the caregivers are present and will be provided based on the child's Medicaid eligibility. Some of the services that are intended to be included would be a number of screening, assessment, evaluation, and case management services, in addition to integrated behavioral health services, tobacco cessation counseling, and alcohol and/or drug use screening using the SBIRT tool. And I would like to, before we move on, just really quickly, California, just as innovative, last year expanded its individual and family therapy benefits by no longer requiring a behavioral health diagnosis for accessing those services. So again, groundbreaking and fundamentally changing the definition of medical necessity for behavioral health services. So children and caregivers can now receive those services if certain needs are identified, including fooding, housing insecurity, discrimination, foster home placement. There's a really long list of wonderful qualifiers that can create an eligibility pathway for families to receive these services. And I think it's a great example of a state not waiting for a diagnosis to approve these services. And it's an innovation that's influenced Massachusetts to make similar changes to its therapy services, and other states are considering following suit. So all it takes is one state to be super innovative. I would just quickly highlight on this slide, our pathways for how we would see success. It's taking something that started in one health plan. Our goal is that providers in California will provide these benefits, will more importantly bill for them so it can help support care delivery and the really interdisciplinary teams that are needed to support these services. That we'll have other states and payers adopt the benefit. And then at the end of the day, we're going to see improved access to care and outcomes for children and caregivers. So over on the next slide, quickly, I wanted to highlight some exciting things that other states are doing in the similar pathway. I mentioned Massachusetts following California's lead on the preventive therapy services, but the state is also undertaking a really innovative value-based payment reform initiative this summer aligned with their new waiver. It's going to provide per member per month payments to primary care practices that are delivering team-based integrated care, including preventive behavioral health services. So the more enhanced and integrated a practice's services are, the higher the payment. And in Colorado, in one of the RAIs that Alex mentioned, they are currently reimbursing HealthySteps sites, certain ones, for delivering preventive psychosocial education. So helping to cover some of those one-off consults that specialists are providing and our tier 3 visits. And in Ohio, the state Medicaid agency is reimbursing HealthySteps specialists for 15-minute preventive medicine counseling interventions that we know can drive really increased quality of care and effectiveness in a really short time, because we know in primary care settings, the turnover goes fast, but if you can make an impact with families in as short as 15 minutes, it is worth it, as we all know. And finally, at the federal level, HRSA just recently released a new grant forecast. It's called the Transforming Pediatrics for Early Childhood, or TPAC. So everyone be on the lookout. But the forecast outlines the potential for HRSA to invest in state hubs to assist with placing early childhood development experts into pediatric practices that can focus on early childhood development well-being for children birth to 5 and their families. And the intended goals are outlined on this slide, but anyway, hopefully ringing some bells, lots of options out there, but it's going to be a wonderful opportunity, I think, hopefully when it's released, for states to really bolster some of their early childhood supports on the preventive side. And then finally, looking at some of the critical success factors that we sort of see at the HealthySteps National Office for promoting innovative payment. The first is just thinking about how you can illustrate value through multiple channels. So really emphasizing, what are value points that you bring to payers, providers, families, and the most important thing I think is emphasizing how you meet families where they are. Thinking about how your program coordinates or can coordinate with other local programs and models to avoid duplication of services. So that's really big. We try to think about in HealthySteps how we stay in our lane. There's enough need to go around, and services should be complementary and not duplicative. And the real potential in proposing and initiating a pilot, and I just have to point this out, all of this wonderful change in California came about, it was definitely influenced by that San Francisco health plan payment arrangement. It took one health plan saying, we're going to do this, we believe in this, to really move a whole state. So I think really, really powerful. We should all think about new innovative payment policies with that in mind. And then finally, just this need to continually think about your data, your value proposition for payers, not being able, being able to think about that in creative ways and how you can continually think about how to change your story depending on, as Alex said, payers' priorities and sort of where market trends are heading. So I think we're ready to move on to the wrap up. In closing, over on the next slide, I think, sort of 3 common themes across all of our presentations, really tracking data and thinking about how family-based models of care can be meaningful in trying to make a really compelling case to payers and stakeholders about the value that as providers you are all adding. Also thinking about reducing the burden of work for providers, making things more efficient, cutting out administrative burden for families, and making sure that they're not having to repeat their stories with duplicative services, thinking about how we can just make things simpler for them and our providers. And then really developing a clear, concise value proposition, especially for those conversations with payers, and feeling really good about the story that your data and that your model or services can tell. And then finally, on the next slide, just a few things to think about. We want to leave a few minutes for Q&A, but feel free to put in the chat if there are any aspects of family-based care that most interested you and things that you want to focus on moving forward, maybe in your practice or where you are. Who you might target. Are there certain payers that you're thinking about? Obviously, Medicaid health plans are innovative, but there can be innovations also on the commercial side. And thinking about, are there metrics or health plan goals that you can align with, knowing which payers you work with. And then finally, going back to that value proposition and how family-based care can help fill gaps within your community, how it can help you meet priority goals for serving the individuals that you're serving within your practices. So I think we'll pause there. I think we were going to try to make that this slide a little more interactive, but we do want to leave time for some questions and answers. So feel free if anybody wants to jump in or put anything in the chat. Alex and I will be, happy to facilitate a dialogue on anything that you all want to ask.
Hi guys, thank you so much for this presentation. I feel like I really opened my mind to a lot of possibilities this past hour. I was wondering, this is pretty basic, but when we go back to this idea of, how to approach payers after talking to your office manager, I'm wondering, if you have any recommendations on how to best start that conversation, or what is the hook to get them into those conversations? Does that make sense? Like if we're starting at a really basic level.
Yeah, it does. No, that's a great question, Jess. So I think things that I try to think about is asking people like, where are your pain points? Because if they're the office manager, they probably know, like, let's say they've been tracking this diabetes measure for 5 years, and they've made some progress, but maybe where do they feel like we just can't quite get above this threshold that we need to get the next round of incentive payments, or we're always like right on the edge of where we need to be. And I think understanding, like, if you haven't been part of that quality improvement process previously, of understanding, like, what have you tried, what's worked well in the past? And then I think that's where you can listen in for, well, as a behavioral health provider or as somebody who really works with families, I wonder if we could try this. Could I listen, join in a couple meetings? Could I sit down with the people who've been doing this work more closely? I think that's where then you can try to get a better sense of where have they, because they'll know, where they've fallen short or where the opportunities are. And I think that's where you can listen with your family centered lens of, well, we've tried this from an individual perspective of, getting patients to take their medications or check their blood sugar levels more often. But I wonder if we could try working with a subset of patients to pilot out, inviting their families, having them be part of the process more, and then kind of watching those A1C levels over time, and maybe starting small with a pilot of like a unique, like a controlled group of patients that you can watch. Because if you can have data to say, well, with these 10 patients, they improve their A1C level or whatever by involving their family, then you have a case for expanding that a little bit more across the clinic. So that's one strategy that I think could be helpful.
That's great. That's wonderful. I was just kind of like summing that up in my mind. And I think that's, those are great places to start. Thank you so much for helping me keep it small.
Yeah.
And Jessica, we had a question. Alex, I don't know if you can go back to the slide that I had on the different state examples. There was a question for the bottom right-hand corner on the potential. Right now, it's a HRSA forecast. It is the Transforming Pediatrics for Early Childhood. Actually, it's one more back, Alex.
Oh yeah, sorry.
No worries. It's a formal forecast now, which means that HRSA is giving individuals notice. The goal is, hopefully, fingers crossed, that they may release an official notice of funding opportunity. We're hearing potentially in April, where entities could apply to be those state hubs that would be responsible for hiring child development experts and then placing those within pediatric practices within the state. We have heard that HRSA may be open on who those state hubs could be, and I think that's going to be hopefully very intentional. It doesn't, our read is that it potentially could be a state agency, it potentially could be a not-for-profit entity, it potentially could be a large health system. I think the goal, though, is there would be one central entity that sort of does the coordination and the collaboration to make sure that those pediatric specialists are placed into the practices where they can reach, obviously, as many children birth to 5 and their families as possible, with a focus, of course, probably on families that have low income and where there's greatest need. So great question.
Jennifer, do you know, is that open to every state, or are there certain states that HRSA is targeting for that?
Yeah, I mean, of course, the NOFO, when it comes out, we'll learn more. But I think, from what we've been able to read, there's actually an early childhood TA center notice of funding opportunity that's out now that has some detail on the TPIC piece. And it does make it sound like, Alex, it will be for all states, but some of the funds will be directed to at least 3 of the states that have some of those ECCS HRSA grants currently, some of the early childhood systems grants. So I think 3 out of the 8 awards will probably go to those states, but then it seems like, other states obviously could apply. Mm-hmm. Great question.
Hi there, I'm in Connecticut, and I really, really appreciate the work, that you're doing. I would love to see this universal across the United States in every pediatric practice. The program, the HealthySteps program, and expanded on that integrated care for all children and youth. It's very helpful to have the states that you discussed, your own California, but Massachusetts, Colorado. It's just so, it hurts my head to think about some of these things and how difficult this is and how every state has to work so individually. So I love this idea of sharing information across states where we can benefit from what has been done other places. So I really, really appreciate this and may pick your brain further as
Of
we
course.
move along. I just yesterday spoke with a group, our Prevent Child Abuse Connecticut chapter, and my message was advocating for integrated behavioral health services from early childhood on, of course. And so I will definitely look at your research on child abuse as well, prevention.
Thanks, Barbara.
Yeah, so thank you.
And feel free to reach out. I mean, my colleague Lisa Powell, who leads our work in Massachusetts, is on the phone. She's also a wonderful resource. But Alex, you said something that stuck in my mind. All of these examples are, except for Massachusetts, but Ohio, Colorado, even California, are opening up fee-for-service codes in new ways, new and innovative ways, which is wonderful because that's what we want to think of. At the end of the day, as a provider, then you still have to bill for all these disparate codes to sort of make up sort of the whole pie if you're trying to fund a new position to focus on early childhood or some other type of family-based care service. So I think what Massachusetts is doing is really breaking the mold and trying to say, we're going to do PMPM payments. And the increasing levels of integrative care that you have, you're going to get higher payment levels. So then, there's still going to be the opportunity to bill fee for service, but this is in addition to that. And so I think the more, to Alex's point, that we can think about innovative payments outside of fee for service, part of it's cyclical. We know that a lot of states say like, well, we can't get to some type of global payment until we have some utilization data. And so part of that is billing fee for service codes for a while. But yeah, Barbara, I think you're right. We've been working with a lot of states who are anxiously waiting to see what California does. And then hopefully we'll copy some of that or a huge chunk of that because, it's always hard to be out of the gate first and do all the hard work of figuring out the CMS approvals and things like that. But yeah, it's exciting to see some of this positive movement on preventive behavioral health services, even on the adult side for caregivers.
Well, I'm looking at our time and we are just about to the hour. So we're so glad that you guys spent your morning or lunchtime with us, depending on what your time zone is. If you have questions, Jennifer and I don't mind putting my email address in the chat box. Feel free to reach out anytime, especially if you're in Colorado and want to, bounce ideas off each other, or if you're just thinking, how do I pitch something to a payer and you just want a fellow, a family-oriented clinician to help you think through that. I'm always happy to brainstorm with you, but just so grateful for the work that all of you are doing with prevention and with treatment with patients and their families, and just really glad that we can all be in this together. So thanks for joining today.
Thank you both so much. This has offered a wealth of information. We really appreciate your time.
Yeah, thanks guys. Have a great day.
Take care, everybody. Bye.
Thank you. Bye-bye.